Hello, I'm Dr. Rautemaa-Richardson, and I have been tasked to cover the superficial candidiasis sections for the Global Candida Guidelines recently published. There are some specific diagnostic challenges when we talk about superficial candidiasis. The main one is that Candida is part of normal flora in the oral cavity, in the gut, vagina, most areas of the skin, and in the airways. So therefore, it is really difficult sometimes to tell what is colonization and what is infection. Sometimes we use fungal load in samples for this, 1 plus 2 pluses, 3 pluses. Or if we do a biopsy and we see hyphae in the tissue, that is obviously a sign of invasion and disease. Sometimes presence of biofilms means established infection, and then finally tissue damage. The reality is that the only way to tell it is clinical. At the end of the day, it's about the appearance of the mucosa and having angry mucosa. This is a picture of angry mucosa, angry skin, not happy for the presence of Candida there. Another diagnostic challenge is the terminology we sometimes use. It is obvious that for superficial candidiasis, they affect the mucous membranes and sometimes skin as well. So you could potentially use the word mucocutaneous. However, I recommend sparing that terminology for the chronic mucocutaneous candidiasis syndromes, which are completely separate disease entity associated with specific genetic factors like STAT1 mutation or ABZ. So CMC does not equal to having recurrent oral or vulvovaginal candidiasis. The other aspect in this is consideration of is it colonization or infection has to do with the host immune status. So many of you have seen the Casadevall curve here, where the midpoint of the x-axis reflects sort of normal immune response, whilst the further left you go, the more immunocompromised your patient is, and the further right you go, the more a strong response the patient is. So the x-axis ranging from severely immunocompromised to hyperreactive. The y-axis reflects the amount of tissue damage. When you go to the left in the impaired immunity, the damage is caused by the invasion of the fungus into the tissues, whilst the further right you go to the hyperreactive patient type, the tissue damage is caused by that exuberant immune response. So the table below the curve is from the same paper, and let's just focus on the Candida line now here. So as said already, in the setting of intact immunity, most Candida presence of Candida leads to commensal state colonization. The further left you go, the impaired immunity side, you see disseminated candidiasis, obviously, but that's where also you see oral candidiasis. You need to have some risk factors for oral candidiasis. It does not happen in completely well normal setting. Now, interesting enough, going to the right, going to the strong response side, that's where your vulvovaginal candidiasis sits. So it's more common in sort of atopic, hyperreactive, allergic asthmatic patients. Therefore, it is actually in real clinical setting very rare for patients to have both oral candidiasis and vulvovaginal candidiasis at the same time. The risk factors are very different. Now, focusing first on the oropharyngeal candidiasis, the list of Candida species associated with it is the classical list there, ranging from albicans, glabrata, parapsilosis, cruzi, and tropicalis. Of course, depending on your local epidemiology. But it is important to note that albicans and parapsilosis particularly are good at forming biofilms, and that is very relevant in the oral cavity. Because dental plaque is a classical biofilm, and these yeasts are hiding in those biofilms, making management far more difficult than if they weren't present. Albicans and parapsilosis are particularly common when you have some artificial materials used for your dental care. So you have dentures or bridges and crowns of concise materials, plastics, and they adhere very well to those. On the mucous membranes, oropharyngeal candidiasis appears normally as a thick white creamy colored plaque or coating. The photo on the right is from an HIV positive patient. So that is the classical finding. But the key here is, again, if you scrape that white stuff off, the mucosa underneath should be angry. It should not look happy. It should be very inflamed, red, and sore. The important thing is that, yes, the Candida hides in these settings in the biofilms, which are mixed biofilms, so bacterial fungal biofilms, and their management is therefore has to have a slightly different approach. We have to tackle both parts of the biofilm to get anywhere. So yes, for this condition, you need to have some predisposing factors. Some of them obviously are not immune dependent. They are about your oral flora, if it has become altered because of antibiotics or maybe use of narrow spectrum mouth rinses, or just having very poor oral hygiene and thick coatings of biofilms on the teeth and dentures and so forth. Of course, feeding your candida in the mouth by drinking or eating something with carbohydrates frequently is an obvious risk factor. But what often is forgotten is that candida thrives in acidic environments. So we know that from vulvovaginal candidiasis, which happens in pH 4.3 or so, so very acidic environment. Candida is happy there. So therefore, patients with reflux disease GORD typically have the back of their tongue coated white just because it favors candida growth in the back. But acidic environment can also be due to frequent drinking of acidic drinks or carbonated fizzy drinks, and then which of course in turn can cause reflux. Now, but the immune side of things, important factor here is, yes, we always worry about systemic immune suppression or systemic immune deficiency. But in the oral cavity, it's important to remember that one of the most important immune defense mechanisms there is saliva. And so the defense can be locally affected by having lack of saliva, and because of medications or for example, radiotherapy for oral cancer in the area. So how do we manage these then? So the cornerstone is to control the risk factors. So we have to improve oral hygiene in every patient. We have to talk about it every time. It is the backbone. None of the antifungals are effective against thick biofilms, so that has to be first tackled. We have to control GORD, we have to consider it, we have to manage it and see how it impacts the situation, particularly in recurrent infections. We have to advise the patient to stop snacking and having fizzy drinks all the time, and have to see if there's anything we can do about saliva production, ask about if they feel they have a dry mouth, if there is some medication we could change. If they use asthma steroid inhalers, they need to be advised to use them appropriately, and if they need a spacer for it, it must be used every time. The last point on this list is antifungals. It's important to remember that for all of us managing these patients, this is the order of actions. Now, looking at the antifungals, the recommendation is summarized in this box. It's directly from the guideline. You can have a look at it in more detail there. But the principle is that fluconazole, yes, it's fine. It's still good. The dose must be 100 milligrams once daily. And there is a bit of a warning there that if your patient has a dry mouth, very limited saliva production, fluconazole may not provide full effect, or the effect is very short-lived, because although you get good levels in blood and in tissue with systemic fluconazole, in the absence of saliva, there is very little fluconazole or no fluconazole in the oral cavity, and the fungal burden in the oral cavity is untouched. So in those cases, of course, topical drugs are definitely preferred, because you get high levels locally, or in some patients immunocompromised, you may need to use a combination of them. For resistant cases, anyway, the clinical resistance, you recommend susceptibility testing, and then your alternatives should be chosen based on them. Itraconazole and posaconazole are listed as alternatives. Echinocandins in some settings, particularly in hospitalized patients, could be an option, but that is not in most settings achievable. It is very important, this is a repetition now for all of these, that you must make sure that azoles are avoided in pregnancy, risk of pregnancy and breastfeeding. You have to ask about contraception from all women in their childbearing age. So this is the summary table from the guideline for firstly the diagnostics approaches with level A recommendation, but looking at the different papers listed here, level A we get for fluconazole and posaconazole. Topicals come less high. They're older, and studies have not focused on them recently, so fewer papers to mention there. Then moving on to esophageal candidiasis, which is partially an extension of the oropharyngeal one, but there are some special features that need to be remembered. So here again, you need to think of the predisposing factors, mainly thinking of, is there an underlying immunological issue here? Have we missed something? Is there, rule out HIV? Think of, is there, for example, something hematological happening? However, then there are some modifiable predisposing factors, as with oropharyngeal candidiasis, your reflux disease, inhaled steroids, and so forth. So all those have to be tackled as before. The treatment for esophageal candidiasis is longer, 2 to 3 weeks, and azole antifungals are first line. Echinocandins definitely can again be used if in hospital setting, but some papers show that there may be slightly higher relapse rate when using them. So again, the summary box here showing that first line treatment is the fluconazole with this 100 to 200 milligrams QD, so definitely higher dose, and itraconazole or voriconazole or isavuconazole are listed here as options. Posaconazole potential alternative. Again, looking at the table of the papers here, lots of different studies show level A recommendation. So as listed here, fluconazole definitely is to use when candida is susceptible to it, but using it using the right dose for it. But then, yes, alternatives, almost any of them can be used. The interesting thing is that when you have a refractory disease, and these need long treatments, and particularly in outpatient setting, or when you don't want to give IVs, there is a need for oral options, and ipraxafungub obviously is broader spectrum new antifungal that ticks this box and gives level B recommendation just due to the lack of data still, but broadly speaking, very effective. Now moving on to Candida vulvovaginitis, VVC. This is now a very different disease from the previous one. So similarly here, the clinical features and signs and symptoms are very non-specific. Oral candidiasis can look like oral candidiasis, but actually it's lichen planus, or it can be other dermatological conditions, or those conditions complicate oral candidiasis. But with Candida vulvovaginitis, it's relatively common to have parallel additional diagnoses, multiple pathologies going on at the same time. The symptoms are very non-specific, and the risk factors are shared. Now, it is hormonally driven, very rare in young girls or postmenopausal women of HRT, hormone replacement therapy. So it's really something we see in the hormonal years, and it's often the sort of bouts of recurrences are triggered by pregnancy, by menopause, so hormonal changes, broadly speaking. So you don't need any other predisposing factors. It's from the right-hand side of the Casa-Deval curve, hypersensitivity component there. A very common risk factor, underlying risk factor, is dry and damaged skin. And the approach to the management of this is very different from the oral one, where in the oral one we say that you have to wash more, clean, brush teeth. Over here we say stop washing it. The skin doesn't tolerate a lot of washing. The more you wash, the drier it becomes, and more vulnerable it becomes. Dry skin is always itchy. The diagnostic challenge here is that colonization is very common in the area in women in their hormonal years. At any one point, 20% of completely well women have candida in their vaginal secretions, and that goes up to 40-50% in pregnancy. So telling colonization from infection can be tricky. The key point to remember is that the diagnosis is not made in the laboratory. A positive swab does not mean that that is VVC. It's a combination of finding, looking at there has to be angry mucosa, but also how the patient responds to the microbiologically effective treatment. If they don't respond to something, or the response is microbiological response is in place, but clinically not, there must be an additional cause. This is just a list from another paper highlighting the symptoms in the left-hand side column, common symptoms seen in vulvovaginal candidiasis, and then the most common differential diagnosis in the other columns. And you can see that vulvovaginal candidiasis shares a lot of the symptoms, particularly with contact dermatitis and vulval eczema. And vulval eczema is relatively common. So, but there are others, lots of similarities to be added to this table. Definitely low-grade herpes simplex virus reactivation would give very, very similar clinical picture. It's important to note that bacterial vaginosis is not a differential diagnosis at all. It presents so differently that it shouldn't even come to mind. But of course, you can have patients who flip between the two, BV and VVC. So how do we manage these patients? as said already, skincare is the backbone of it all. You have to stop overwashing any feminine hygiene products. Just let it be. Use an emollient cream like on baby's bum, high volume, daily, many times. Healthy skin can fight infection. Antifungals come as a support and of course as a treatment. So again, the box from the guideline summarizing what we recommend. So the evidence is still very clear that the single dose of fluconazole 150 milligram tablet is a very effective approach, safe approach, and alternatively, at risk of pregnancy for other reasons, you can use intravaginal pessary, for example, clotrimazole 500 milligram pessary with the same effect. Ibrexafungerp has been shown to be very effective in this, and it can be used, but particularly to be used in case of fluconazole resistant infections, and but again can't be used in pregnancy or risk of pregnancy. So that is for the recurrent disease, this once weekly protocol for 6 months, either with fluconazole or clotrimazole pessary, is very effective, and it's been shown to be safe, doesn't need any monitoring for liver function or anything. So it is the diagnostic evidence is that yes, you need to isolate the candida and you have to do susceptibility testing and so forth, particularly when you start getting recurrent disease. You know what you're actually facing and treating. But for acute single episode, of course, you can treat without diagnostics. Yes, level A recommendation for fluconazole, same level for ibrexafungerp, but the focus should be for this drug definitely in resistant infections. It is important in these cases always to confirm that if the clinical resistance matches with microbiological resistance, and if fluconazole clears the candida, but symptoms don't clear, rethink rather than change drug. There are so topical azoles are at risk of pregnancy. Alternative for fluconazole resistant infection is definitely vaginal nystatin. That's for safe to use in pregnancy and at risk of pregnancy. Interesting new drug in development still is oteseconazole, been licensed in the US now, and it is very effective for in recurrent vulvovaginal candidiasis, as it provides its half-life is 128 days, so it covers a short course, gives you good protection for nearly a year. But the issue with it obviously is again that it's not appropriate to be used in pregnancy, risk of pregnancy. So you have to plan your family planning carefully in advance, and it can be difficult to use in younger women. So that is the tables and the data we have on this topic. But in summary, in contrast to maybe the other systemic candida infections with these superficial infections, the bottom line is if candida does not respond to microbiologically effective treatment as judged by susceptibility testing and post-treatment a negative sample, you are probably getting the diagnosis wrong. Maybe it's a dermatological condition you need to consider, and not only fungal. Or alternatively, you have forgotten to consider your biofilms. None of the azoles are active against biofilms, and you need to think about improving particularly oral hygiene but not vulvovaginal hygiene. That is the sort of wrong thing to do. So that's the summary of that. I thank you for your attention.